Ladies and gentlemen, welcome you to the next session. We are truly as on the TV show. Maria Libura will moderate the session entitled Private or Public Health Care. Maria will introduce our guests here and online. We have excellent speakers. Let us start with our participant online. She could not come to Krakow. Janina Petelczyc, PhD, one of the best specialists in social security systems in Europe, associate professor at the Warsaw School of Economics. It's a novel representation of the Warsaw School of Economics here in the room. Tomasz Rowiński, psychologist and someone very much involved in the reform of the mental health reform. Again, the same school and the think tank affiliated to the high school, Warsaw School of Economics, and Artur Białoszewski, also working for the Warsaw School of Economics and the Warsaw University of Medicine, also working for the Warsaw Chamber of Medical Doctors, and Michał Zabdyr-Jamróz, the head of the Public Health Chair at the Jagiellonian University, and he's also a political scientist, is taking a different perspective on healthcare systems, and Magda Władysiuk, a key participant to this round table, MD, PhD, who takes a top-down approach, and also a graduate of Jagiellonian University. Representatives of two cities are today at the table. Warsaw and Krakow are represented, and you, Maria, are representing Gdańsk. This is a topic of concern concerning the developments in the healthcare systems. Let me start our debate with the definitions. Private and public, what does it mean in the field of healthcare system? I think that the best way to start will be to ask this question to Dr. Zabdyr-Jamróz. He actually is doing such definitional and notional work on an everyday basis. Thank you. Thank you for giving me the floor. Thank you for your hospitality and excellent organization. Well, to answer your question, I must say that some scientific papers have already been published on some definitions. We propose those definitions to, in a way, correct the public debate. Commercialization, marketing, privatization of healthcare. We use these terms in a number of contexts without defining them. Let's start with the privatization. Let me start with the following remark. I think it's of relevance. Each privatization is different, and private can mean different things. For instance, private to some extent, but still non-profit, or private purely associated with the second sector, meaning private and working for the profit, capital profit. And add to that yet another level, I mean, for the market, we can analyze goods and services, and we can have a capital market. And this perspective will change our views on the operation of the goods and services market. So all those perspectives need to be integrated into our reflection. What does it mean, privatize? Well, it means that you hand over some assets to the private sector. In the healthcare, some decisions have been made in the majority of public healthcare sectors. There are some private or privatized areas. For instance, primary healthcare. And if we talk about commercialization and commercial operation of healthcare organizations, we need to define the very notion of capitalism. The capitalism of shareholders or the capitalism of stakeholders. Let's start with the first one. In the first case, the capitalism of shareholders, the focus is on profit. The profit to be produced and generated by shareholders, investors in a specific project or company. Don't forget that this is just one solution promoted, for instance, by Milton Friedman. And the only social responsibility here is about producing profit. This is not the best solution. We have an alternative solution, the capitalism of stakeholders, and the stakeholders, the stakeholder group is larger than just shareholders. And the responsibility, social responsibility in the second model is not about maximizing the profit for the shareholders, but also to take into account the well-being of the staff, local community, contractors, consumers, and so on and so forth. So as you can see, plenty of dimensions and levels where some decisions need to be made, and the same is about marketization. Marketization is closely linked with privatization, and even these two terms are considered as equal. The marketization means the model of being and staying competitive. Don't forget, there is a bulk of research literature analyzing different models of businesses present in the healthcare sectors with the outcomes of their business and the consequences of the model of operation adopted by them. And if we decide to have private healthcare companies, profit-driven companies, such companies will be particularly sensitive to financial incentives, so the pricing and the appraisal. In other types, there will be the issue of compliance, some soft requirements, not specific parameters. But if the solution is primarily based on capital companies, private businesses, if we choose that model, we need to be extremely cautious. And we need to carefully define the orientation of development, because these actors are extremely sensitive to profit, to financial incentive. They are profit-driven, and it often goes detrimental to the quality and the level of access to healthcare and social solidarity and fairness in access to healthcare, which as such is a value of the healthcare system. Thank you.
Those famous studies, which were also largely discussed in Poland as well, for example, studying how rescue medical teams work, it showed that private entities decided to focus on those aspects of healthcare provision which were best valued and which yielded the largest profit, and was necessarily the same with securing the patient's safety. And in such a mechanism, the savings were made on the personnel, or the focus was more rather on a quick reaching the patient rather than performing a thorough examination of the patient. Another question, which is we are on a more general level now. In a moment, we will move on to more detail. But my question to Ms. Petelczyc. The place of healthcare in a more broadly understood social security system. What is that place? And if we take into consideration that those two systems are interconnected, and everyone here could name examples that savings in the healthcare system translate to savings in costs or savings in the social security system. The tendency in Europe is to reintegrate those systems. In what way the progressing commercialization of the healthcare system offers a chance to allow for such integration? First of all, I would like to say that despite of being sick, I am able to participate. I did receive medical help. I think this is a pertinent question because the Article 67 of the Polish Constitution with regards to social security, telling about the universal rights, I think that these are indeed interconnected aspects, and it is impossible to analyze one without the other. I mostly specialize in the old age pension system. So this regards senior citizens, and here we can clearly see that in our system with our current demographics, we will probably be forced to increase the age at which people retire. People keep saying we cannot increase it further because we don't, the people are not healthy enough. So the COVID aspects aside, the lifespan is extending, but this is one of the aspects that I've been noticing. If politicians decide to carry out a reform, whether in the healthcare system or social insurance systems, social security systems, one cannot be changed without changing other aspects. We cannot increase the retirement age without investing in prophylaxis, in prevention, so that people can be professionally active for a longer time. Obviously, increasing of the retirement age would mean a better situation of the social insurance system. But the focus is on reducing disability pensions, occupational diseases. We can see that investing in the healthcare system results in streamlining of the functioning of the social security system. But it's better to finance the healthcare system. This is not just this does not just yield specific savings, but it simply gives us a better healthcare situation of the society. I liked my predecessor's discussion about different phases of commercialization. Some element of availability of not just public but also private healthcare systems can be a positive thing, can yield positive results because it can increase availability of services, deburden the public system. Some people with higher revenues can shift towards the private system, which will save up resources for the remainder of the population. That might also help in managing the available resources. However, all that I'm saying right now in the context of commercialization needs to include an asterisk, a caveat. From the perspective of social security system and healthcare systems, the main challenge in commercialization is reducing inequalities available to the systems. I also have this one aspect that I've been focusing on is the system of education, system of healthcare. What I underline, in Brazil, two different systems are in place, the private and the public system. So the private system is effective. It carries out tasks which should be carried out by the healthcare system, but obviously it is not available to everyone. And the problem is that the people who are chosen to govern, these are people who are affluent, who already have the capacities. This is how it works in Brazil, but we know that this is a common idea for democratic systems. This affects how the public system works. So they are more likely to make cuts and limitations to the public system because this doesn't affect them and their loved ones because they have access to the private system. So taking into account the experiences of Brazil and other countries, I think it is very important that we step away from the traditional economic theories. Instead, when talking about the commercialization is inevitable, but we should definitely ensure good regulations. We cannot allow for general cuts that would increase the gap between the two types of society, people in the public system and the private system. If I can address that. A similar experiment was carried out by the Netherlands in 2023. They basically stepped away from the public system for the benefit of private insurance companies, also with regard to providing the basic scope. After 3 years, they withdrew from this because a large discrepancies between the availability of services to the population, to the society was observed. So they backtracked. It was a failed experiment. I will refer to some aspects about that later, but we are observing that in Poland as well. Even when we look at the medical subscription market, mostly in large cities, and also specific age groups benefit from those subscriptions. And even in the private subscription model, we are observing lack of availability. So even this private system sometimes is backlogged. So the question of private or public, one in terms of equality of access, and secondly, who is the owner of the system and what rules should be obeyed. So in Poland, the systems are sometimes confused and mixed, but what is sure, what is certain is that there is not enough regulation. We do not take into account nuances, the culture of our society, which impacts our behaviors. The fact that in the Netherlands, in a country which is more mature in terms of shaping the social security system, Poland is far behind the Netherlands, and even if they were unable to carry out such an experiment successfully, shows that the issues of availability are of key importance. What is particularly noticeable in terms of global health threats, healthcare systems are the pivotal infrastructure of the state. It is something similar to, let's say, the electricity grid. it's a critical asset, critical infrastructure, which is a bit harder to measure, it's less measurable, but is necessary also in crisis situations. It needs to be fast and efficient. So the example of Brazil is not so far away from our situation. When under the more leftist rule, Brazil tried to avoid critical healthcare situations by importing Cuban doctors. Yes, there was a whole discussion with regard to health, with human rights. The idea was interesting, but cooperation with Cuba was problematic. The problem was that the payment had to be made to the Cuban government and not to the doctors personally, but the idea was also an interesting one. So this shows the paradox of similar systems. But we do not need to look so far away to Brazil. I'm looking now at Mr. Rowiński, because what happened to psychiatry, especially pediatric psychiatry in Poland, is actually a similar situation. Right now, access to psychiatrists in the situation of underfunded systems, now only private services were practically available, which increased the cost of visits tremendously. Right now, the cost of an appointment with a psychiatrist who is available in Warsaw, the costs differ whether it's a pediatric patient or an adult patient. In the case of pediatric patients, the costs are incredibly high. It's a system similar to the dental healthcare system in Poland, so it's all privatized. How the previous systems, which so let's talk about community psychiatry and the reforms, which now resulted in such a poor situation.
Well, we started with the need definition, and I believe that it sums up the key dilemma. Before the need was identified, there was no reaction to alerts and alarms raised in the psychiatric community. Nobody saw the need for reform. At some point, we all realized that there was a need for psychiatric consultation. A large-scale problem with an impact on many sectors was identified. But you know, it was not out of the blue that we saw the crisis. So the need, I would repeat, made the decision makers to think, okay, we need to do something. For child psychiatry, it was easier to introduce some solutions. Actually, for the majority of issues in children, you don't need psychiatric consultations, and psychiatrists is needed just to prescribe drugs. So psychiatrists are needed in 10% of child consultations where you need pharmacotherapy. So the first reference line was a pre-doctor consultation, and that was done for the first time in Europe. We knew that the first line help should be a help without a doctor for children and for adolescents. We simply knew that we didn't have enough doctors, and moreover, children did not need the doctor. So we have 500 consultation centers right now. I do remember the early stages. When we elaborated the reforms, we tried to calculate the needs. and in 2018 we said it would be about 1 billion zlotys. So we started with the needs of the children, the population data, 2 stages of calculation. So we had the number of children to be taken care of within the the public sector. And we came up with 501 billion zlotys. And Professor Kozik-Janas was actually surprised when I gave her the number, and she advised me, just don't give that number to any people at the Ministry of Health. I wouldn't agree. I'd say, listen, we need to know, and we need to tell them, because they need to know how much money is needed to cover the needs of children. And I told the ministry what the cost would be, and they said, okay, and we were right. And that was a success. We also had some shortcomings. And the shortcomings are identified at the second reference level when there is a doctor, a psychiatrist, who comes in. And here the reform was not successful. Why? Because everybody loves children. Everybody was interested in the second reference level, and there were too many cooks who cooked the broth. And actually, nobody took into consideration the differences between private and public sector, and namely the approach to the profit and the modus operandi used in each of them. We failed to define precisely how the second reference level should look like, with all the stakeholders and the division of powers. It's not because because doctors were not enough. No, we actually identified the needs, we calculated the needs and the expenditure, and we knew how many doctors we had, and we wanted to accommodate these doctors. So first level of reference, safe help, and then move to the second level of reference with all the estimates being done. And this second reference level doesn't work properly because of the lack of courage on behalf of the payer, who is the monopolist on the market. The payer fails to realize that we are right now in a different situation. It's a free market situation. And the decision is needed ahead of the processes. And you just said that there is an exponential growth in the prices of consultation, like 1,800 zlotys for the child psychiatric consultation, or 600 for the consultations of a 1 day. So let's say that we have such prices in the private sector, and the public sector says it's only 800. So no wonder that the doctor would choose the private instead of public sector. So again, how do we define the public value of the services? In the public sector, the profit is less important. Well, public entities would always generate profit as well, can generate profits, but that's of secondary importance. And you said that this is a sort of a stomatologization of psychiatric care, and we are just halfway between this commercialization and non-commercialization, and some decisions, groundbreaking decisions, are now being made. And in psychiatry, we are fighting against such high prices of consultations. We can pay out of our pockets, it's true. And this is the first choice for everybody. And if somebody does not have enough money, they have to manage otherwise. So we are in a watershed moment. And again, it's not about availability of doctors and the choice of the employment, the public or the private sector. It's more about the organization of public psychiatric services, and this is up to the decision makers, politicians, and the National Health Fund. Well, we'll see what will come up from the works they've been doing. There is a third level, third reference level. There are psychiatric hospitals, and they're never commercial. In psychiatry, such stays are actually quite expensive and it could generate profit, but it doesn't work. Hospitals are usually public hospitals. Well, if something which is too expensive even for the upper middle class, it will never be made commercial. Very expensive chemo or longer hospital stays are too expensive to be covered out of the pocket. And this will always be public. But don't forget this Brazilian model where upper middle class living in large cities can spend their own money on more expensive services. And with that, we have the inflation of costs. But you know, this commercialization will never start in the small villages or towns. It's always about big cities. I can imagine a private or commercial hospital, psychiatric hospital, offering short rehabilitation stays. There is a demand on the market. So, for some reasons, such psychiatric hospitals are never privatized. They're always public, and they will be public with doctors, teams of doctors, and research and training centers. The inpatient part will always be there, and the outpatient part is fighting for survival. So this is the ownership question. Is it a public entity or a commercial company? I know that at some point we had the idea to change the ownership structure of hospitals, and the reforms was partly successful. But the discussion is not about the ownership structure. The discussion is more about access and the level of access in both sectors, public and private. And in public sector, we have delays in tariffications. We had 2 announcements by the Minister of Health last year only. That would be my first point. And the second point, the reform of a hospital network, it's important as well, but I will not go into details. And thirdly, it's about our public decision on what to finance. What does it mean, public and private? If you pay out of your pocket, you will always pay more. But don't forget about social solidarity enshrined in the Polish constitution. Then everybody will chip in to better finance more effectively our needs. Is it about competition or lack of competition? Should the providers compete with one another? Should insurers compete with one another? So these are the vital questions. But the constitution says state should act as an auxiliary, and state should provide help to citizens and assist citizens in keeping their health. So it's about the social covenant and our public consent. Myself, as a doctor, I would say I would like to earn more, but I'm not that much willing as a citizen to pay more. It's about the conduct and behavior of all the stakeholders in the system. The public hospitals, the National Health Fund, and public and private companies, plus healthcare professionals. I do lectures on public health, and people tell me I'd like to earn 40,000 zlotys. But is it a norm in the system? Do we want to have such a target norm in the system? Let's just compare. It's not about earning peanuts, but it's not about earning huge sums as well. So it's about the consent, and we don't have such discussion.
Let me clarify my position. Public value is something I've spent a few years on, and something I understand well. And I think that's something that the social system should secure. So the needs of the citizens should be secured. But on the other hand, the fact that commercial companies appear and they provide services, this is a healthy situation. It should be the case in every country where economic freedoms are respected and everyone is free to develop a company if they have an idea for a company. I think that's okay. But the problem is that even when we're talking about being competitive, it makes sense if we do have the resources. If we don't, there's no point, then it needs to be stolen. And hospitals do tend to poach entire teams of professionals. So basically it's a fiction talking about competition. And especially when the National Health Fund wants to secure competitiveness. When a monopolist like National Health Fund wants to secure monopolies, that sounds like a joke. So as a state, I think, and this was the tendency to create medical academies to develop new, create new doctors and nurses. Not to mention the quality, but if we do not develop new healthcare professionals, new staff, new community experts, no competition will be in place. Coming back to the origins, if a doctor can be poached, he dictates the terms. So in capitalism, no matter how we define it, if many people, if many entities want me, I dictate the terms. But let's flip the discussion about regulations. I know I'm jumping here and there, but my question was whether we should regulate the public and private system. We are currently regulating the public system, but in the past decades, there was the idea to create both the regulated private and public systems. What we are creating right now, the situation is that everyone can express their opinions. We are not regulating the attitudes of various entities. They are under-regulated. I am not a fan of the regulations which are adopted in the National Health Fund because they are too far-fetching. But various healthcare professional groups who set specific terms. Is it ethical? Because we are not regulating that. This is something that's visible in many cases. There are irregularities both in the public and in the private sector, so the quality can be lacking. Another thing which we are not regulating is how is the patient supposed to find his or her bearings in the situation if they are jump between a private and public system provided doctors. So this is not regulated, this is abusing of the system. The question is why it is allowed. So the problem, this is not discussed about. I, as a patient, do not want to wonder, should I pay, do I go to public or private? But if I'm supposed to struggle to get an appointment, once privately. So let's say my child has a disability certificate and I have to wait 1.5 years for a public neurologist, but privately I can get an appointment within 1 week. Should we agree to this situation, knowing that if we don't have the situation, today's discussion about contributions, which touches upon whether private or public, does not basically go towards the discussion of what system do we want to have in the future. We do not discuss the different impacts on the system. The question is, what should we consent to? And let's calculate about the consequences for the average citizen if we increase the contribution, if we force the citizen to make a surplus co-payment and additionally pay out of pocket, then we end up with an American system which is not efficient. So let's ask ourselves the questions: how much do we want to spend on health? And then think about whether private or public. And then let's be honest, this is incredibly difficult to regulate. Larger players, countries which are more affluent, are also failing to do it. For example, the example of the Netherlands. It's about not allowing for cherry picking between the health insurance, private health insurance societies. So this discussion is great. It's very dynamic. We should keep it. But allow me to make an additional meta remark, because I think in this discussion we tend to present two different perspectives on the healthcare system. Is it a branch of economy, or is it the critical infrastructure of the state? Because this is the spectrum where we can move back and forth. It's not either or. I think in Poland, despite of all the global threats, we tend to think about the healthcare system as commercially and not in terms of ensuring public safety. And one more remark: there was an experiment regarding the economic views of common people. People were asked whether a retailer who is the sole provider of snow shovels, can they increase prices from $5 to $50 if there is a heavy snowfall? Can people do it? And Polish economy students were the only ones to answer yes, this would be allowed. Other respondents from other countries said it was immoral, and this situation should not be used to make a quick profit, which would be in line with the liberalism spirit and Adam Smith. So this question about ethical aspects of certain actions and the moral hazard of healthcare services providers, this is something which is not discussed sufficiently. But coming back to healthcare professionals, how do they found their bearing in the current situation? And I'm directing my question to Mr. Białoszewski. First of all, thank you for having me in this panel. It is my pleasure to be able to speak to you. It is my privilege to take the floor as the last one. I was waiting patiently, but I bid my time. My intention was to start differently, but we mentioned liking the services to the private dental sector, stomatalization. My wife is a dental expert. The negative feel of that discussion is not something I like. My wife is a pediatric dentist. She treats the pediatric patients both as part of the private and the public system, so both publicly and commercially. And to her, she doesn't care who pays for the treatment. She doesn't differentiate between the level of services. Maybe it's the type of the materials that she uses because of reimbursement issues. But I am also a great advocate of social solidarity. But in the context of what is happening, we cannot ignore certain aspects of the public discussion where we know that the National Health Fund has a deficit of between 15 to even 30 billion Polish zloty to cover for limited and unlimited healthcare services. Saying that the National Health Fund will pay for treatment in unlimited services, since they are unlimited by definition, the fund is obliged to pay for those services. What do healthcare professionals say about this? I will not be saying as a representative of the Supreme Medical Council. We are talking also with nurses, with physiotherapists, with pharmacists. We have to clearly say that for the different medical groups, what is most important is the general health security and our professional security of specific healthcare professionals. So the security and safety of safeguarding the safety of those medical groups and of the general population. With regards to what was said before and what I said about my wife. My wife also wants to make a good living. She wants to earn. This is why the healthcare professional associations are there to secure the interests. Thank you for the good introduction to the difference between the public and the private sector. If we look at the current state of affairs in Poland, we say that health is a public good. But this is something which should not be the subject of competition. No one fights for, let's say, the fire brigade, securing fire safety. If something is on fire, the fire brigade simply comes. In the case of securing health, we have different actors. We have to clearly say, because it was already mentioned by the respondent online, the article in the Constitution does not safeguard a full access to healthcare. It is a bit different. We have to think about what we can afford as a state in the context of how we finance the guaranteed services package or basket. In the context, what was mentioned is that doctor in the private sector earns 3 times more than in the public sector, because it's for the benefit of the greater public good. I ask my students, them, I might open the Pandora's box, but women in childbearing, in the professional age, so in a working age, and men in the working age, knowing that she's also in the childbearing age, will you be more willing to hire a man or a woman? Students say, oh no, there should be no difference. But if it's your budget and it's your company, 99% choose hiring a man. Because it's not on the people who work, so pharmacists, doctors, nurses, they should not be responsible for organizing the system. They want to make a good living, obviously, to make an honest life. We are not working in a vacuum. The future budget of the National Health Fund is, if I'm not mistaken, 222 billion Polish zloty. The inflows are around 700 billion Polish zloty. The expenditure is 900 billion. So we can see the huge gap. The Polish Institute of Hygiene already assumed that 30% of that amount would need to be covered from the state budget. So we are in a situation that we are trying to provide the patients with something that we cannot afford. So we have to adjust the current guaranteed services package to our capacities, because currently we are in debt. We are using state bonds. And in the current demographic perspective, by 2050, over 30% of people will no longer be in working age. So the inflows from the health contribution, with a 9% contribution, with a lot of people leaving the job market because they will retire, the inflows into the system will be lower, so the resources will be lower than what we have at our disposal currently. So the situation will become more dire. In preparation to that, we need to say that there will be a collapse, a clash. For 2 years now, we have been carrying out, as part of evidence-based health policy, we have been carrying out a survey with around 1,000 respondents, doctors. We asked them what to them is most important in the system. And the financial issues no longer are the main ones that are mentioned, because their wages increased. Yes, but also professional emigration also is no longer a strong trend. We mentioned the Cuban doctors who were exported. Cuban doctors that are exported are a big hit. But when we look at Germany, they spent around 37,000 Polish zloty per citizen. If we standardize it against our demographics, this means that over a billion 900 is spent by Germans. How are we to compete with their resources? If we do not pay them sufficiently, they will move on. In Szczecin, which borders with Germany, we have been observing such a big problem that the doctors there move around across the border just 30 kilometers and pay free and get paid 3 times more. They don't look at whether it's a public or private German system. They simply get paid more across the border. This is the role of local governments to make sure that individual interests do not dictate the narration. We have to focus on ensuring the health of the society, secure it. We are responsible for that, but we also have to keep in mind the interests of healthcare professionals. And to end up, I'd like to say that whether someone who sells the snow shovels, can they increase the cost? If you look at, let's say, the RIA medication that is available at a petrol station or online, obviously this is a drug that you need urgently, and if you get it, if you buy it in an emergency, it's more expensive. Well, a lot can be said about the changes in the ethical approaches of states, and shaping those ethical attitudes is important for the efficiency of systems. For example, in Scandinavia, there is less discrepancies in the wages. Currently, in Poland, it is expected that there will be a big discrepancy between wages of doctors in different specializations. Obviously, a lot is being said that all healthcare professionals should be paid well, and both doctors and nurses have managed to get the right resources. But the discrepancies between wages is a question regarding attitudes towards the lack of social equality. The question of whether progressive taxes even this situation out.
Definitely, we had some delays in financing the public staff. Without the financing of the staff working in public, we will not have the truly public health care. Well, for years, doctors agreed to conditions below their expectations. Secondly, we need to know how far we are ready to go. I know that some professional groups have their expectations and that there is an inflation of costs. But costs rise not only because the increase in wages. We need to make a choice about a model of financing in any system, whatever the country. Their wages have been on the rise. But up to that, the mechanisms that we need. The systems will always have their deviations. That's the feature of the system per se. But that's a simple question. If you have your university students and ask them, would you prefer to work more or earn more? Everybody, well, 99% would say, I would like to earn more. Medicine is not an easy path of study. A lot of resources, cognitive, financial, intellectual. And we tend to forget that. We tend to forget that being a doctor is a challenging thing. And actually some actors would use and abuse of the system. And actually people would choose specialties of demand. Hospitals are still public, and it's not a coincidence. It requires more time and more money. When you talk to the heads of hospitals and managers of hospitals and you ask them how many new doctors would like to work there, today no young doctor, the graduate of the university, would like to work at the hospital. Only the older ones. They would choose a different sector. But you know, even with an increase of university graduates, we still do not have enough doctors. And just have a look, the specialty pulmonology. And there are no sufficient numbers of pulmonologists in the hospitals. They all work in the private sectors. But don't forget, the director of the Warsaw University of Medicine is a pulmonologist. Let me just give you one more example. I'm really impressed with the Swedish system. And you have biology drugs that are different therapies. Some are cheaper, some are more expensive. Just use the most expensive. And 90% would use the cheaper ones because they believe that there are no differences in efficacy. Well, definitely that would depend on the branch of medicine and on the actual individual effectiveness. So this culture of cost is a sign of maturity in the system. It's not only about how much we gain, it's also about how much we can afford. Like doctors would tell me, I'm here to treat, I'm not here to earn money. But just try to identify the levels where errors in the systems are generated, where deviations are generated. It's a low level, intermediate level, and a high level, and just find where there is a waste of money. And I can give you a number of examples of my child who requires care, and actually with the money I have, I can manage 3 consultations over the day. So that I'm telling you that just to tell you that there's a plenty of factors coming into play. Access, money, and also the training of the staff. Is it a quality training? You know, it's about the decision making, a tiny decision making. Should I have to travel? Should I need some diagnostic tests? Should I do anything more? So again, it's about financing. What do we want to finance? What do we want to accept as a compromise? The ethics, social solidarity. There is no such debate in Poland. It's all about money. It's not at all about the true social solidarity. And it's always about the protection of groups of interests. And we see only this clash between the private and the public as something immanent. Are they really hostile? Do we know that? How do we know that? Well, vital questions. Now let us move to Michał. Michał came up with the concept of structural egoism of the Polish system where everybody fights against everybody. It's an original sin of our reform after the transition period. Well, I wanted to refer to what Artur has just said. Stomatologization of the Polish healthcare system. My wife sends you all her greetings. And we reciprocate. We reciprocate. But well, be honest. private healthcare organizations are not a problem, and people working there are not a problem at all. We see that they have some ethos of work, that they are passionate about their job, and they do everything to help. And that's the structure that we have. And sometimes we need to make difficult decisions, and that's the moment when the structural egoism comes into play. It's not about how much we pay, it's not for what we pay, and how are we going to settle our accounts. There are no resources, there are no competition between the entities. Over the years, we were told that competition is good, but think about doctors who compete for patients. Well, that's a great idea. But let's think about the hospital competing for new doctors, and 2 or 3 hospitals poaching just to attract new doctors. And there is one whole unit that needs to be closed at one hospital because all the doctors there were poached by another hospital. Competition as evolution, by definition, induces waste. Somebody will drop out of the race. Somebody will lose. With the shortage of resources is there, we need to be careful about the competition, because if the resources are limited and the competition sets in, there will be even less resources available. In other words, you say that the state should impose a 5-year plan to manage the resources available and to allow competitions. The National Health Fund wants the competition about its own resources. Well, competition can be a nice thing to improve quality. However, it should be strictly managed. The patient actually is not able to assess fully the quality of healthcare services. So the competition is more about the quality of service at the reception desk, whether the lady there was smiling or not, and less about the quality of the procedure. But competition is regulated everywhere. There is no such thing as unregulated competition. There are no such fields and no such industries. For instance, the product cannot be harmful to the client. No, that's not what I meant. You gave a Swedish example. Sorry for stepping in, but I need to conclude on that point. Well, I believe that we need to define whether the public system that we have is able to secure and fulfill the existing needs. And for us in psychiatry, the objective was to build up a system that would respond to the needs of children and youth. In Sweden, we have a public insurance, for instance, the National Health Fund. And I have an issue with my eye. I consult the doctor. Well, something with the retina, you have to have a surgery, and in 90 days you should undergo the procedure because that's the standard. And the care coordinator takes responsibility, and he says, okay, you have slots available here and here. We have no slots for cataract operation in public hospitals, but you can go to the private one and then we will reimburse you the costs. But that's a different type of regulation. As you can see, there is a clinical need of the patient, and the system as a whole tries to secure and fulfill that need. But what actually should be regulated? That's the point. There is a top-down approach on demand, on the offer, but we do not analyze the offer through the demand. Demand meaning medical needs. Well, from the perspective of the demand, it's catastrophic, whether it's public or private. Why do we say that private is better than public. Life expectancy, mortality in oncology, infantile death, or condition of teeth. Among Poles, there are no major differences between the care being provided in the public and in the private sector. There's no good sector within the sector. Well, the private sector is in a way a substituting sector for the private one instead of being complementary one. That is why you have subscriptions or commercial systems, and we have patients with insurance in the public or in the private sector. And in the private sector fails, the patient will definitely go to the public one. Care does not mean one-off service. It means a continuity. If there is a move back and forth of the patient between the private and the public, it means that both do not work well. It means that the private offers only one-off services and the continuity is ensured by public one. And it's not about responsibility. It's about the very essence of the system. We cannot afford to have the private sector only. The Netherlands, the UK, Germany, none of them can afford to have only a public healthcare system. We have two, public and private, and as a patient, I want to know what my path is. And instead of having a sort of a whispering marketing, I should be well informed about the quality of care, and whether it's public or private, it shouldn't matter. In psychiatry, our assumption was that the health is a public good, like education. You don't have to go to the doctor to be in a well-being. So it's good to have some coordination effort at the lower level, not at the ministry level, but at the lower level. With the ministry, it's never easy. You know, when the minister comes in, says, I've got an idea, and after 1 month, the idea is dropped. But when you go down to the level of a community or a powiat, it's much better to organize and arrange things. I'm still in the area of pediatric psychiatry. And here we saw that thanks to a coordination and cooperation between stakeholders, considering epidemiology and treatment standards, with all this coordination, the system is able to provide care to all of the children. So what's the message? Widespread in the media about the child who needs to be taken care of. Well, the message is that nobody takes responsibility. And if you look at the National Health Fund, the National Health Fund defines the need in terms of the number of healthcare services. So basically the services are provided, because the National Health Fund would usually finance that number of services. And now I will step in. Yeah.
Very often, and I'd like to underline this, the problem is not in whether it's public or private, it's how the settlements are made, how the things that I mentioned, and we talk about coordination, better methods of settlement, thinking about the value for the patient in the long term. These are things that are currently being developed in the systems, but they were strongly promoted by commercial insurance companies in the US. So this so-called socialism is something performed by private companies. And I'd like to underline it even more so when mapping out all those things we talked about. If something can be public, it can work, but if it's commercialized, it can also work horribly for the patients. Commercial, I mean, using commercial rules, so legal regulations which force to focus maybe just on the financial balance. But a classic example is the problem that we had for nearly 2 decades, that the main problem of the healthcare system are a certain type of healthcare facilities. But now the studies show that when we look at the financial results, at the profit and loss account, those public healthcare facilities, so this type of facilities is even more efficient. The third change regards change in the executives. Well, yes, we can also consider about the executives and how to get rid of them. The question of, is there anyone who we can blame? Can we blame specific people? Let me add that British research indicates that introducing external consultants in healthcare to hospitals would statistically act to the detriment of all possible factors, both health factors and financial factors. So if you, the myth that we can take external experts, this has been demystified. Coming back to Artur Białoszewski, the issue of retaining personnel is very important. So how do the professional association see it? As it's not the case that one reason for the leaving of employees is not just finances, but also the fact that some healthcare systems are easier to work in. I understand you are talking about working conditions, yes, and the options for development, choosing a given specialization, a given career. Yes, that's a good question. Our research shows that in the past, specialists used to work in the public system because that offered some permanence, some stability, sense of stability that was offered by public hospitals. But now, because the system is destabilized, we are observing internal migration. We are not talking about emigrating to different countries, but migrating within the Polish system, migrating between the public funded and the private sector. And the consequences of this instability are clear. A hospital in Żywiec closed its departments, moved the patients to other hospitals. And it's not the case that all of the healthcare professionals will go to their homes and they will just stay with their kids and be idle. And in January, when the contract is up and running again, they will be there. No, obviously, they will take their positions in different elements of the system. If the public-funded hospital will not be there, as the hospital I'm talking about was an interesting example of public and private cooperation. This cannot be rebuilt, so these professionals will no longer be available. You can cheat to your mom, to your dad, but your accountant will always know the truth. In the end, the balance sheet will be clear, the profit and loss account. An external auditor will always discover the truth. If someone leaves a fund and says that they will pay 10 to 15 billion, and we know that 0.2 billion is in the reserve capital, where are they supposed to take those funds? From the state bonds? This is the source of financing that was used by the previous people in power. So the treasury bonds have already been used. I want to tell you, when you are sick, do that by June or even March next year. After that, the funds will run out. Well, depends on whether it's a part of limited or unlimited services, but beginning of next year, if you need to be ill, do it then. Beginning of next year is the best time to have a deterioration of your health. So, like patients don't die in December, the research shows they tend to die in January. If the demand that is can be regulated by contracts, if it would result in contracting taking place later, from the perspective of the organizer of the system, the health needs are not carried out because the hospital has been closed. So we should think about the minimum minimorum, the minimum that we find acceptable. So Article 68 of the Constitution should guarantee access to equal access to healthcare services. In dental care, it's teeth 1 to 4, and the molars are not reimbursed. And we should bear in mind, I keep saying that I am an advocate of social solidarity, but if the state moves something to the hands of patients, then it's very difficult to force the state to retake that responsibility. Poles simply choose private dentists. One politician said that, I want to say who. When preparing for this panel, I had some long discussions at the university, and the president of the NHF, Professor Schulz, said that there were some pathologies observed in the unlimited healthcare services, and therefore a reform should be considered because people tend to visit outpatient specialist care experts more than they should. I'm not going to. My friend is an allergologist, and she had a patient with a stomachache. Why are you coming to me with a stomachache? I am an allergologist. Because you were the only doctor with whom I could get an appointment. Are you a doctor? Can you help me? Well, yeah, I guess I can. Maybe let's say it was some food allergy, but it was not a health problem with a allergologic factor. So this is a pathology. So the unlimited services result in a pathological situation where right now we have an overuse of outpatient specialized unlimited services. I can see that I'm talking a bit too quickly for the purpose of interpretation. It's the portfolio. The portfolio will tell us, and our wallets will tell us what we can really afford. So I will agree with how we finance services, especially in outpatient care. This is a pathological situation, because even if we use the lowest rate and we use 78 Polish zloty, the average time is supposed to be between 30 and 40 minutes. If we pay another thing is that we create pathologists saying that some services which are more specialized, which have to be moved to specific service groups, the doctors create more appointments to finance their needs. So statistically, Poland has the most doctors' appointments. But we also heard of another mechanism. We shifted from a fee-for-service system in hospitals. We moved to a lump sum or flat rate system. But fee-for-service in the primary healthcare. When I, as a doctor, hear that in the primary healthcare we will be talking separately for each disease, so if I have a stomachache and I go to a primary healthcare specialist, will I get a full examination or not? Will he just refer me to a gastrologist? So we created a mechanism which, in my opinion, is a good starting point on how to create a good system, but this was not the target system. We created a pilot program, and now we can see that it got out of control. No country can afford this. Just to finish up, when we start to measure of see where the patients are shifted. The problem is that we also do not collect the data. We don't really know what is happening. We also don't collect certain data in outpatient secondary care. We also do not have sufficient data on the private sector. But soon we will have more possibilities of collecting data. We have to consider all the factors. This system is very complicated to design. The Dutch were developing their system for 20 years, and we want to do it quickly. No, we have to sit down, analyze the data, see what we do not have available. So the question of what we can afford is also difficult.
What to skip? We think that we can afford everything, potentially, but we know how much hospitals are indebted. Just compare Czechia and Poland at different levels of out-of-pocket expenses. We have no buffer. We are standing in front of the wall and we are checked. But in Czechia, you have no competition between commercial care and public care. But there is competition between insurers. But they didn't introduce the psychiatry reform. Yeah. Very briefly, or maybe not. It requires some explanation. We've forgot to say one thing. There are solutions to the issues we've been discussing. So the duplication of consultations, the inverse service pyramid. It's about appraising the services in terms of long-term health outcome. For instance, we compare longitudinally the health of the patient, like for 1 year, and then the provider is rewarded. Well, you can do only that in specific therapeutic parts. Why? Because it's not easy to measure such indicators. And moreover, there is a move back and forth between sectors. Some services are taken from the private one, some others from the public one. But there are solutions, and I believe that the discussion should be organized on how and to what extent they can be implemented, or maybe the two systems could be to some point integrated or coordinated. And let me just raise one more political argument Janina has mentioned. Decision makers represent usually middle class or upper middle class. They can afford. They simply can afford. And actually they don't care that much about those challenges. And as a result, we are not on the same page. And we have a step-by-step privatization by neglect in Poland. And that would be my conclusive remark. But I wanted to raise that point, that solutions are there, and that there is also a political dimension to the organization of the Polish healthcare system. Yes, in Poland, in small towns, there are people living with chronic pain only because of their disability and mobility exclusion. They have no access to specialized doctors. So we have a sort of a humanitarian disaster in smaller towns which are excluded in terms of mobility. Yeah, shortly. In psychiatry, we have tested for 6 years a solution of budget per population. It's not FIFO for service. It's more about the population budget, and the budget is split between more serious and less serious conditions, and we have very clear results. 170,000 inhabitants. So in this population, we had 7,000 or 5,000 absence days less with that budget, and the hospital stays were shortened by like 4 to 4 days. So this budget per population really works. But the Ministry of Health is resistant, despite scientific arguments. Well, you can do demonstrations, but mentally, the National Health Fund and its IT system are not ready for such fixed budget per population. It's without any limits for some services. There is just a population, a predefined population, and a fixed budget. Then you allocate the budget according to the needs. Well, I will state some truism to conclude. We are talking about the system, but the system is not responsible for our health. We are responsible for our health. Outcomes can be assessed, indeed. But let me just quote an anecdote from a cartoon when there is a patient coming to a physical therapist and says, but this is exactly the same set of exercises I was given by a previous therapist. And the therapist asks, did you exercise? And the patient answers, no. So therapy, adherence and compliance, that's also a point, a case in point. Social security system plays a role as well, and everybody knows that it, well, you know, and it's a pyramid. Well, Janka will have a moment for conclusive remarks as well. But there is a gap. There is a gap in the social system, and this pyramid of age is definitely something that cannot be avoided. We need to count on ourselves. And Janka, about the social insurance institution and the financial pyramid. You know, my neighbor is just drilling, so sorry for the noise. I don't think that the social security system in Poland is a financial pyramid. I think that we simply need to increase the retirement age. And I think that with an increased retirement age, there will be a substantial self-financing capacity in 30 years. I think that the discussion was extremely insightful, especially that the Polish healthcare system is extremely intricate. Regret that I cannot be there here. Together with Dr. Tomasz Rowiński, a lawyer, we made a study on social security contributions, and the findings were that the contribution should be transformed into yet another taxation. The proposals made today go quite to the opposite directions. So instead of reducing the contributions of those who are the most affluent, we simply need to reorient the money, rechannel the money generated by such flows. Thank you. Thank you very much for this very insightful debate with a lot of perspectives being present. This is an added value of this conference. This is a platform where you simply discuss to see what options are on the table. To sum up the main lines of thought, well, we had different visions of the health care system, which may be considered as a part of state's critical infrastructure or a part of state's economy. What to do with limited resources? Is it better to limit the guaranteed package of services, or is it better to streamline the financing? For that, we would need to know what we'd like to and what we are ready to pay for from the budget available in the system. Because the time is up, we need to end, and now we can continue outside the room during the lunch break. Thank you.